Here's an example. So I like to introduce real examples just so you see that it's not just a sort of theory or something like that. So dabrafenib is a treatment for unresectable or metastatic BRAF V600 mutation positive melanoma. That bit doesn't really matter. I mean, it matters, but it's melanoma, so it's skin cancer, or a form of skin cancer, and late stage. If you're unresectable or if you're metastatic, you're fairly advanced. So dabrafenib was in this case, the new drug, and recently approved was another drug, so new but not quite so new, called vemurafenib. And so the question was, this new drug, dabrafenib, should we be using it instead of vemurafenib? There's no head-to-head study. No study anywhere in the world randomized patients to dabrafenib or vemurafenib. So if we're going to make an estimate of how well dabrafenib works compared to vemurafenib, we're going to have to use indirect evidence. And fortunately, there was indirect evidence. There's a trial called the Break3 Trial, which randomized patients to dabrafenib or dacarbazine. Dacarbazine is an older treatment for this metastatic melanoma. There was also a trial that randomized patients, the BRIM3 trial, that randomized patients to vemurafenib or dacarbazine. And so it's back to this idea that, in principle, we could compare how much better vemurafenib is than dacarbazine, and compare that difference to how much better dabrafenib is than dacarbazine. There is a problem, however. Can anyone spot it? Well, yes, they had a dacarbazine arm, but remember, it's not the same patients. This wasn't a three-armed study. We didn't randomize patients to vemurafenib, dabrafenib, or dacarbazine. They're two separate trials. And so we are assuming, in making this indirect comparison, we're assuming that the dacarbazine patients in the vemurafenib BRIM3 trial are similar to the dacarbazine patients in the Break3 trial. Now, that's something we can, to some extent, check. We can look at the age of patients, we could look at their gender balance, we could maybe have some indications or markers of severity of their condition. But of course, that just lets us know to what extent the patients are a bit different. It doesn't tell us whether they're too different to compare. So potentially this is a very powerful way of identifying a treatment effect when you don't have head-to-head data. Do a comparison, adjusted indirect comparison, but you have to be careful to check that the patients in the dacarbazine arm or the common arm in one trial are sufficiently similar to the patients in that arm in another trial. Now, partly in response to that challenge, in recent years, researchers have started looking at something called matching adjusted indirect comparisons. Matching adjusted. Now, what quite often happens is that a manufacturer has individual data on their product. In fact, they always have. They are the people who have the individual data on their product. But if the other drug is made by a rival, they've only got aggregate data. So in this, I don't remember who the companies were, but in this context, the makers of dabrafenib will have individual level data on the Break3 trial. But all they have for BRIM3 is the published report in a clinical journal on the BRIM3 trial. And the published report doesn't give you individual data, it gives you an aggregate level. It tells you what the effect was overall. It tells you average age of patients. It tells you what proportion were male, etc. But this creates a possibility. If you've got individual data for one trial and aggregate data for another trial, you can reweight your trial so that the patients have the same aggregate characteristics as the other trial. So for example, try and make it, suppose in BRIM3, the patients were, half the patients were male, half were female. But in Break3, a third were female, 2/3 male. Now, it may not be a great example because for metastatic melanoma, gender may not be important. But suppose gender was a predictive prognostic factor. What you could do is reweight your individual data so that instead of it being a third female, 2/3 male, you could reweight it so it's 50-50. So your data then has the same characteristic as the BRIM3 trial, which had, say, 50-50 male-female. And that's a matching, adjusted, indirect comparison. Yes?
For example, if there are not only one prognostic factors, there are several. Age,
Yes.
gender, and the BMI, for example. So in that case, how we can give the weight or that any method?
Yeah, that's a very good question. Essentially, and usually there will be several prognostic factors. Yeah, I only use the idea of one to make it simple, to give the idea. What you actually do in that situation is you, using your individual data, you use some form of regression analysis, which relates the health outcome for each patient to their characteristics, to these prognostic factors. And so that analysis would allow you to say which factors are prognostic, which have a significant impact. And then you could use that model to predict what the outcome would have been if patients had the characteristics in the other trial. So in a sense, you're simulating what Break3 tells you would be the outcome if you had a different mix of patients. So you've done an analysis of individual level data that shows to what extent, I should know metastatic melanoma better than this. There'll be some measure of, there'll be various things that are prognostic. And so you're then able to, in your regression model, to predict that if someone has these characteristics, we predict this outcome. And so then you can take the characteristics from the BRIM3 trial and predict what would happen if it had been based on these individual patients.
So you mean that we will use the full data of the Break3 and then how can I say, get the prognostic model and predict the results from the brain screen. I see.
So it's quite clever.
Yeah.
It's not easy, and it's not going to be sort of always accurate, but you can see how it's quite sophisticated. And so it's a move on from this. This, we just take it on trust. The C arms are common to both trials, so we can then just look at this difference and compare it with that difference, and that's it. But that, as I say, is vulnerable to these two control arms being a bit different from each other. So this approach, matching adjusted indirect comparison, is one step forward. It's making the comparator arms more similar. It's kind of exciting. You know, it's sort of producing something new from existing data almost. But inevitably, it's not straightforward. And what we often find is we don't have very good data on what factors are prognostic. You know, there's some we think definitely are, some we're not so sure, and that's an issue. Okay. So it's a reweighting approach. And so basically, it allows you to control for differences in baseline characteristics. So in this case, if the dacarbazine arms had patients with rather different characteristics, this approach, in principle, will allow you to adjust for that. So it's quite a step forward.